We're going to go to our next speaker, and then we're going to ask questions at the end.
Perfect.
So our next speaker was chosen because she's another expert in vasculitis in this area. There's been a lot of advances in guidelines and trials and whatnot, and we've asked Anisha Dua from Northwestern to talk about the assessment of patients with GCA and PMR.
Thank
you, Dr. Dua.
Thanks for having me. All right, so this was a nice introduction. We talked about therapies, and now we're going to go back and figure out how to recognize, diagnose, and monitor patients with these diseases. So assessment of PMR and GCA. I always talk in cases, so we'll start with the case. This is a 75-year-old woman, comes into clinic complaining of fatigue, a 10-pound weight loss. Over the past month, she has pain in her shoulders and hips, worse in the morning. She's got some pain in her MCPs, but no swelling, and stiffness lasting an hour. She's tried taking ibuprofen, which bothers her stomach. She hasn't had improvement in her symptoms. She has a history of TMJ, coronary artery disease, hypertension. She smoked for 20 years, quit when she was in her 50s, and her review systems is otherwise negative. Her SED rate's 40, her CRP is 4, and she's got a little bit of anemia. So conditions to consider. This is a talk about PMR and GCA, so you should consider PMR. But she does have the classic clinical presentation with the shoulder, bilateral shoulder stiffness and pain, as well as hip girdle. And inflammatory markers were slightly elevated in her, and we'll talk a little bit about that after. Late onset RA, this can be seronegative, it can be seropositive, but this is something where a lot of PMR patients, or not a lot, but a proportion of PMR patients can have peripheral joint involvement. You can check rheumatoid factor and CCP. A lot of times in rheumatoid arthritis, you'll have more of a symmetric small joint involvement. In PMR patients, the peripheral involvement is more often asymmetric and can involve the large joints, and we'll talk about that also further. Hypothyroidism can affect the elderly or anybody, so check a TSH because you can have muscle soreness from that. Malignancy, you definitely want to think about this in a person who has a smoking history and a month with rapid weight loss. You also want to think about this if she has a lack of response to low-dose glucocorticoids. Myositis should be on your differential. Check a CK. Again, with myositis, it's usually painless, and you have weakness on exam. With PMR, there is pain, and it's not actual weakness, so a CK can help figure that out, and so can a good clinical exam. Osteoarthritis of the neck and hips can result in these kind of symptoms, but normally you can look at the radiographs and inflammatory markers and other clinical clues to help you figure out what's going on. I'm not going to talk about this in detail, but basically we all know what PMR kind of classically looks like with your shoulder and neck involvement, bilateral more so than the hips. It does predominantly affect females, but the main thing here is that this is one of our more common conditions, especially in rheumatology. And so there's a 2.4% lifetime risk of this disease. So a lot of these patients will actually be managed in primary care settings, and they may come to you only when they already start having refractory disease, and it's up to you to kind of go back and figure out, was this really the diagnosis? How do I monitor these people moving forward? Stiffness in the morning is common, more than 45 minutes. This is the stuff that my patients tell me. I feel like I got hit by a bus. I have trouble turning to get out of bed, more difficulty getting dressed, combing my hair. So it really does impact quality of life, but it does not impact life expectancy. So what lab studies can we use? We've talked about the SED rate and CRP. Some of our therapies affect these studies, of course, and so that makes it difficult. But this one study from the 2000s said that CRP is a more sensitive indicator of current disease activity. This study, about 10 years before that, said that ESR is the most useful laboratory parameter in assessing PMR and GCA. And this study said, actually, people can have PMR and GCA and have a normal SED rate and CRP, even though it's only in 1.5% of cases. So what do we do with that? So the majority of patients will have elevation in their inflammatory markers, and we do know that clinically, low-dose glucocorticoids should result in rapid clinical and serologic improvement. I check both of these at baseline, and I see if one of them is abnormal and if one of those tracks with disease activity, or if both of them do. And then I'll check that one more frequently moving forward. But it's important to also remember that a lot of things can affect these, right? So as people age, they're going to have elevations in their at baseline for their SED rate or CRP. And also things like anemia, pregnancy, IVIG. I mean, I've looked at my Epic inbox and seen this elevated SED rate, and I'm like, oh my God, what's going on? Only to realize that they just got IVIG a few days ago. So you always have to go back and think about the other things that could affect this, including malignancies and infections. Anything that basically causes increased proteins and red cells to stick together, dropping faster is going to basically increase your SED rate. So they're helpful, but not necessarily always completely helpful. Relapses, you can have relapses clinically without an increase in your SED rate or CRP. That happens in 20 to 50% of patients. You also can have increases in those inflammatory markers without having actually any clinical flare. So in those patients, you don't necessarily have to bump up their prednisone. I repeat the test, and I think about other options. These people are immunocompromised, they're on steroids, do they have an infection going on? Do they have maybe a large vessel GCA that's being missed? So these are things that you want to step back and consider if you start seeing these constantly elevated inflammatory markers, but not your classic PMR relapse signs. Relapses are common with glucocorticoid tapering. This happens 20 to 55% in the first year. And we all have seen those patients where you're just stuck between 4 and 3 milligrams. And for some reason, every time you bring it down, they start getting worse again. So this is something that does happen at doses less than 5 milligrams a day. It is worse with rapid glucocorticoid reduction. I'm not as bold as my colleague here in trying to get these patients off of steroids in 4 months. But you know, there are the folks who just feel good and they want to come off steroids and they're like, I took this for a couple of days, I feel awesome, can I stop now? And you have to have a good conversation with them about the importance of not coming off too quickly because they will have an increased risk of relapse. All right, so audience response. Which of the following findings does not support a diagnosis of PMR? Ultrasound with subacromial and subdeltoid bursitis, an ultrasound with long head biceps tendinitis, increased plasma IL-6 and TNF-alpha. And then, oh, that didn't work. You guys better get this right. Interesting. All right. So I'm going to talk a little bit about ultrasound findings. And actually, so plasma levels of IL-6, I know Dr. Spear was talking about this. We know that there's elevated levels of IL-6, not as consistently TNF-alpha in both GCA and PMR. And we know that there's an increased risk of relapse and recurrence if you have persistently elevated CRP and IL-6 levels. Now, I don't personally check IL-6 levels consistently in these patients. I have a couple who are insistent on it. But we do know that IL-6 is really important in the pathophysiology of these diseases. Oh. Okay, wait a minute. Hold on, sorry. Oh, all right. Okay, so classification criteria. So again, classification criteria are for trying to enroll people in clinical trials. They're not meant to be diagnostic criteria. We do sometimes use them interchangeably. But the main things I wanted to point out here, and all of my little fly-in boxes came in early, but is basically that we have our patients who are older than 50, bilateral shoulder aching and abnormal inflammatory markers are kind of those initial criteria that they include. The things I wanted to point out is that absence of other joint involvement gives you an extra point. Again, that small joint peripheral arthritis can mimic rheumatoid arthritis, but it's usually asymmetric and non-erosive in PMR. And then the last piece here that was important is this bursal or synovial and periarticular inflammation that can be seen. It's actually the inflammation that leads to the limited range of motion, so it's not weakness. And some of these folks can have pain if you palpate deeply on their muscles. So imaging in polymyalgia. Ultrasound and MRI are two potential options. Ultrasound can help you detect this bilateral subacromial or subdeltoid bursitis. It's really good at looking at the shoulder. It's less frequent, it's less useful in looking at the hips and trochanteric bursa, but it does increase your specificity from 81 to 91% when you look at those classification criteria. And if you're good at the ultrasound, you can also go look at the joints and make sure that there's not proliferative synovitis that is consistent with rheumatoid arthritis. It's cheap, it's accessible, but it is very highly operator dependent. MRI, on the other hand, is good at looking at the pelvic girdle tendons, and you actually can see extrasynovial involvement with edema, tendinopathy, and effusions, and you can actually see some localized myofascial involvement as well. It also responds to therapy, but this is more expensive, although it's reproducible. And when should you consider a PET? I guess whenever you can get it covered, which is rare. But honestly, it's something that I do consider when patients are not responding to glucocorticoids and have other risk factors. Some of these PMR folks will have these systemic sort of manifestations of fevers and weight loss and just not doing well. So if they don't respond to that glucocorticoid and you're still not sure what's going on, they've got low-grade fevers, you really need to think about things like malignancy, and that would be one indication for trying to get a PET scan. What would you see on the PET scan? The typical pattern is this Y-shaped uptake, so you get uptake in those shoulder bursa, and then along the spine in the interspinous bursa. So again, it's helpful for looking for large vessel vasculitis, malignancies, and working up fevers of unknown origin that can look similar to polymyalgia rheumatica. Again, it's expensive, access is difficult. All right, so our patient responds to 15 milligrams of daily prednisone. She has complete resolution of her symptoms in 2 days. Her SED rate decreases to 15. Her CRP is normal. Over the next few months, you wean her prednisone. She's down to 7 milligrams daily and schedules an urgent follow-up visit. Now she's got 3 weeks of new onset right-sided headache, scalp tenderness, malaise, shoulder, hip discomfort, difficulty getting out of a chair and combing her hair. She's got jaw pain when eating. Her vitals are normal. She doesn't have any abnormalities on her exam of her temporal arteries. And she's got pain with abduction of her shoulders, some scalp tenderness, no bruise. She has elevation of her inflammatory markers and a little bit of an anemia. So what's the relationship here between polymyalgia rheumatica and GCA? We know that they affect similar demographics of people, and about 15% of PMR patients will go on to develop GCA, so the most important thing is really asking about symptoms of GCA at each of their visits. And Dr. Spira mentioned a couple of the facts that, people can have clinically standard polymyalgia rheumatica, and if you look at autopsy studies, they actually can have large vessel inflammation in their autopsy studies, or if you do a temporal artery biopsy, they may show some inflammation there as well that goes more along with GCA. Doesn't mean you should be biopsying all these people looking for GCA, but there is clearly a relationship there, and you need to be asking about GCA symptoms when you're seeing these folks. On the flip side, 40 to 50% of GCA patients will have symptoms of PMR. Even if they come in with the classic cranial symptoms of GCA, no PMR symptoms, their relapses actually can be PMR-type symptoms, so they are closely related. Which of the following features most significantly increases the likelihood of GCA? Headache, jaw claudication, a history of PMR, or scalp tenderness? All right. Yeah, so we've got jaw claudication and history of PMR getting the highest votes here. So, when I ask fellows or colleagues, what are the things you think about when you're thinking about GCA? Of course, the first things that come to mind are headaches, vision loss, right? Scalp tenderness. These are the things we ask about right at the beginning of our encounter with the patient. But this was a meta-analysis looking at over 14,000 patients, and these categories in the yellow boxes basically didn't meet the likelihood ratio cutoff of 2. So this doesn't mean that they aren't part of GCA. They are. So scalp tenderness, weight loss, vision loss, headache, fevers. These are all things you will see in your GCA patients, but they don't actually increase the likelihood of the diagnosis as much as some of the things on the right here. So limb and jaw claudication are significantly increased your risk of, or your probability of having GCA. Temporal artery abnormalities, and then the AION and previous diagnosis of polymyalgia rheumatica. So what does our patient have? She has scalp tenderness, she's got a headache, she might have jaw claudication, she has a history of TMJ that makes it a little bit difficult to tease out, and she has a previous diagnosis of PMR. So she also has this elevated SED rate, CRP, anemia. You'd think she has GCA. So you're going to start her on, you're going to increase her prednisone to 60 milligrams daily. Now, the recommendations from the ACR and Vasculitis Foundation are that in patients with suspected GCA, we should do a temporal artery biopsy over an ultrasound for the diagnosis. The EULAR guidelines are to do an imaging study, so to do an ultrasound usually of the cranial arteries and then also the axillary arteries to try to make the diagnosis. Now, I underlined here that is assuming high expertise and prompt availability of this imaging technique. Some of us may have access to fast-track clinics or ultrasound at our institutions, and others do not. But at this point, the recommendation is to pursue a temporal artery biopsy, and that's what you decide to do in this patient. But the surgeon's not available for 2 weeks. So what should you tell him? I mean, you could tell him, I want this biopsy right now, but it's probably not a battle worth picking, because we all know that actually biopsies can be positive even after the initiation of steroids is longer than 8 weeks. But over time, you start losing some of those classic features. So lesions start evolving into this healing stage with more fibrosis. vascular remodeling, less inflammatory infiltrates. This was an older study that basically showed that you have the best yield if you do the biopsy in the first 2 weeks, but you still do have positive yield even if you wait for more than a month. And this was an interesting one where they actually had biopsy-proving GCA, and they re-biopsied those patients at variable time points and saw that even at a year, close to half of these patients still had positive biopsies. So ideally, you would get it done within 2 weeks of starting the oral glucocorticoids over waiting longer, but if you have high suspicion, you should just get a biopsy when you can get it. What else should you tell them? To do one or both sides. The yield increases 5 to 10% if you do a bilateral biopsy, but there have been studies looking, at patients and doing bilateral biopsies, and only 6 out of, or like you can see the numbers there, but basically a very small proportion will have unilateral arteritis. So the recommendations are to do a unilateral over a bilateral temporal artery biopsy. Now, I do a unilateral biopsy if someone has classic manifestations, like a right-sided headache and a pretty clear clinical picture of GCA. But there are cases where I'm really a little bit fuzzy, and in those cases I might get or they have a diffuse headache and I'm not totally sure what's going on. In those situations, I might consider getting a bilateral biopsy. The other thing to note is that you want to get a long enough segment because they shrink. When you send them to pathology, you need your pathologist to do multiple slices, so we recommend getting more than 1 centimeter. The pulse is more palpable here, but you want to get the biopsy up here because it avoids damage to the facial nerve. So, what are you looking for on the biopsy? You basically have inflammation at the adventitia of the blood vessel, right? And the inflammation's moving in, it disrupts and destroys the elastic lamina, and then you start getting obliteration of your lumen, difficulty with blood flow, downstream ischemia, leading to your clinical manifestations of the disease. So that's what you're classically looking for, and of course it's great if you have giant cells because it's giant cell arteritis, but that you're not always going to see them in the biopsy. And in fact, if you put 14 pathologists in a room, which this study did, and had them look at the same slides, they're going to disagree on a lot of them. So they're looking at, a couple of them agreed that these patients definitely don't have GCA. A couple of them agreed that these other cases definitely did have GCA, but the majority of these, the pathologists disagreed on the interpretation of that biopsy. So we're putting a lot of weight on these pathologic diagnoses, and there is just some discrepancy here, and that becomes even more difficult when the read says something like this: mild periadventitial inflammation, no giant cells or disruption of the internal elastic lamina, scattered areas of medial fibrosis with vascular remodeling, inconclusive for GCA. And you're going to get these results, and you're going to be like, okay, what do I do with that? So, the classification criteria, again, when we're thinking about putting people into trials, they have been updated in 2022. And you can see here that this is, again, you already have high suspicion, you've excluded your mimics. Some of the things that were added are the PMR type of symptoms, jaw or tongue claudication, sudden vision loss, and I just highlighted some of the things that our patient has. But really what I wanted to focus on here is, our patient has some of these. We're not sure if this biopsy could be read as positive, but really we also have to look at other types of imaging studies. And these are now included in the updated classification criteria, which I think is really important. So this patient improves dramatically with an increase of the prednisone. I start tocilizumab, wean down the prednisone, 15 milligrams daily. She continues to feel clinically well, but her SED rate and CRP increase on repeat tests. So what do you want to do? Do you want to monitor her clinically? Do you want to get some large vessel imaging? Or do you want to increase her prednisone back to the 20 milligrams that she was just on, that was effective, and repeat her labs on that dose? All right. So a couple people want to do all of these different things. In this case, what I would recommend doing is to get large vessel imaging. Now, the way that we're diagnosing a GCA right now, the majority of us are doing temporal artery biopsies. And again, that is sort of our gold standard. But I just talked about some of the difficulties with interpretation and how there are issues with temporal artery biopsies as well. Europeans are doing more temporal artery ultrasound because there is higher expertise there, but we are sort of integrating that into fast-track clinics and getting more training here. But only about 50% of people are doing large vessel imaging at the time of diagnosis. Now, the recommendations from the ACR and BF are that we do non-invasive vascular imaging of the large vessels in any newly diagnosed GCA patient. I mean, they go so far as to say that we should do it even in suspected GCA with a negative biopsy. Now, I decide to do that based on pretest probability and what my clinical suspicion for the disease, but we really should be getting baseline large vessel imaging in these patients with GCA. We know that there can be involvement of the bilateral subclavians, the axillaries, and Dr. Spear also mentioned that, people can get aneurysms and dissection of the thoracic and aortic abdomen, or thoracic and abdominal aorta at even 5 or 10 years out after their diagnosis. Extracranial involvement is seen in up to 80% of GCA patients, and so we really need to be looking for this because by the time you're hearing some of the bruits, some of the damage has already been done. How do we diagnose it? Now, in my pre-learned slides, I went into a lot more detail on the different imaging modalities for evaluating large vessel involvement in GCA, and I just put a couple pictures up here. We've got PET scans, we've got CTAs, we've got MRAs. Now, conventional angiography has been really replaced by these non-invasive imaging modalities unless you're really trying to do some sort of specific intervention. So PET scans, again, hard to get coverage for, but they can show nice lighting up throughout the large vessels and respond quickly to treatment. That's one of the hard parts. Once you get the PET approved, they've probably been on prednisone a while, and a lot of times their PET activity is going to decrease. CT angiography is what I tend to use in trying to look for large vessel involvement in my GCA patients. You're going to see concentric inflammation or thickening around the blood vessel wall. And then MRAs can show areas of stenosis. They're a little better at picking up edema, enhancement, and active inflammation than CTAs, but I use MRA more primarily in my Takayasu's patients. So I generally tend to use CT angiography. All of these can add different types of information to your assessment. You don't need all of them, but they do add complementary different types of information. And here's just sort of a take-home chart sort of to look at the different pros and cons of these different imaging modalities. Again, angiography isn't used very much. Ultrasound is very operator dependent, but I think that we are getting more adept at using it both in PMR and in GCA, which is great. CT angiography, you have your high radiation, but it's quick. And then MRA, there's a couple of contraindications there, but it's a little bit better at picking up active inflammation. PET scans are really good at picking up active inflammation and looking for malignancies, but they're very expensive. So my take-home points are that ultrasound findings of subacromial and deltoid bursitis and biceps tendinitis actually increase the specificity for diagnosing PMR. PMR patients have elevated circulating levels of IL-6, and this is correlated with disease activity as well as relapses. Limb and jaw claudication, temporal artery abnormalities, AION, and prior PMR significantly increase the likelihood of a diagnosis of GCA. GCA patients should undergo a temporal artery biopsy, ideally within 2 weeks of initiating glucocorticoid therapy. Unilateral biopsies are okay. Sometimes there's a reason to do both sides. You want to make sure they're more than 1 centimeter. And then large vessel involvement is really under-recognized. It's something that should be assessed at baseline with non-invasive imaging modalities. If I see involvement at baseline, I am repeating these studies periodically, and we can talk about the nuances there. But we need to be recognizing large vessel involvement. These patients have higher risks of developing those pretty serious complications down the road and often require higher doses of prednisone. And I kind of stayed on time. That's
Excellent.
it.
Perfect.